Hello, this is Dr. Armin Shahrokni. I'm a geriatric oncologist with more than 12 years of experience of taking care of older adults with cancer. Today I'm going to talk to you about 3 decades of geriatric oncology from Anecdote to Mandate, story of evidence-based transformation from 1996 to 2026. If you enjoyed this talk, please subscribe to this channel so we can grow our community on YouTube, which is very important. So the history of geriatric oncology is a medical discipline's journey from the periphery to the core of cancer care. Over the 30 years, geriatric oncology has evolved from a field defined by exclusion of older adults to an evidence-based specialty. This journey was driven by a fundamental shift from relying on physician intuition and chronological age to mandating a standardized functional assessment. The story is one of the scientific progress, proving that the patient-centric approach not only preserves quality of life, but also reduces harm and improves outcomes. The central theme of this triumph is evidence over age-based bias. So there are 5 eras in the geriatric oncology. The first era is from 1996 to 2000, second one is from 2001 to 2010, third is from 2011 to 2018, fourth is from 2019 to 2023, and the fifth one is 2024 to present and future. So the Act 1, which was from 1996 to 2000, was the awakening, documenting the systemic problems of exclusion and the need for a new approach for older adults with cancer. The second act, which was from 2001 to 2010, was forging the tools, standardizing the core instruments of the specialty, such as Comprehensive Geriatric Assessment. The third act was the Predictive Revolution, developing validated tools to predict patient vulnerability before treatment begins. The fourth act was the Interventional Breakthrough, proving that geriatric assessment guided care actively improves patient outcomes and reduces toxicity. And Act 5, which is the current act, is focusing on global implementation, equity, and integration into daily practice. So from 1996 to 2000 was the era of awakening. A field awakened to the reality that older adults are systematically excluded and misunderstood in oncology, transforming anecdotal concerns into hard evidence. Foundational evidence was focused on quantifying the problem. Lichtman in 1996 focused on natural decline in glomerular filtration rate necessitating precise chemotherapy dosing. The impact of this study was establishing the fact that chronological age is a poor proxy for biological reserve and GFR-based dosing is critical. Yanchik in 1997 focused on detailing the impending cancer burden in the age, providing the demographic justification for the field. This paper justified the creation of a specialized geriatric oncology units to handle the coming surge. Bernabe in 1998 focused on exposing widespread systemic failure in managing pain for elderly cancer patients in long-term care. The impact of this study shifted focus towards supportive care as a critical component of treatment. Finally, Exterman in 1998 focused on proving that comorbidity and functional status are independent variables. The impact of the study laid the intellectual foundation for multidimensional comprehensive geriatric assessment, or CGA. In another major study, Hutchinson in New England Journal of Medicine in 1999 transformed anecdotal concern into a matter of public and regulatory policy. By quantifying the exclusion of older adults from cancer treatment trials, it became the most cited paper in the field's history. The direct consequence of this paper led to the National Cancer Institute, NCI, and the Food and Drug Administration, FDA, to mandate broader inclusion criteria in clinical research. In 1999, the ELVIS trial challenged the therapeutic nihilism. It investigated single-agent vinorelbine in elderly patients with advanced non-small cell lung cancer. This trial demonstrated a clear improvement in both survival and quality of life for patients who were able to receive single-agent vinorelbine over just best supportive care. This was the first major randomized trial to proved that chemotherapy could provide a tangible benefit to older patients with advanced lung cancer. At the time, was directly challenging the prevailing view that older patients, simply based on their age, were too fragile for treatment. So an insight from the awakening era was that chronological age is a poor proxy for biological reserve. We must measure, not assume, a patient fitness for treatment. During the awakening era, the field successfully transitioned from anecdotal observation to documented evidence. Systemic exclusion from trials was proven to be a barrier to progress, and the need for multidimensional assessment tool was firmly established. In 2001 to 2010, we were able to forge the tools. The focus shifted from documenting problems to standardizing solutions centered on validating the Comprehensive Geriatric Assessment, or CGA, as objective measure of biological age. In a study by Repetto et al. In Journal of Clinical Oncology in 2002, a direct comparison was made between CGA versus the standard ECOG performance status. In this study, many patients who were deemed to be fit based on ECOG were found to have hidden, underdiagnosed, underappreciated, aging-related vulnerabilities that could have impacted their outcomes. This proved that the standard oncology metrics consistently and dangerously overestimate physiological reserve of older adults. In the same era, a new paradigm emerged with the notion that more is often or many times just more toxic. In the MILES trial, published in JNCI in advanced non-small cell lung cancer, the investigators compared doublet versus monotherapy in older patients with advanced non-small cell lung cancer. Doublet showed no survival benefit over monotherapy, however, at the cost of increased toxicity when patients were given doublet. There was a lasting lesson with this study. This trial taught the oncology community that for older adults, treatment intensity does not automatically translate to better outcomes. It established the principle of treatment de-intensification, which would become a central theme of the future research. In the same era, the 6 pillars of geriatric oncology was created. In 2005, International Society of Geriatric Oncology, or SIOG, task force recommended functional status, comorbidities, social support, cognition, psychological state, and nutrition to be the 6 major components of CGA. These recommendations provided the first standardized, internationally recognized list of domains that must be assessed, creating the global blueprint for geriatric assessment. In the third era, from 2011 to 2018, was the era of Predictive Revolution. The field developed sophisticated, validated tools that can accurately predict a patient's risk of severe treatment toxicity before chemotherapy. In one of the major studies, the CARG, or Cancer and Aging Research Group Toxicity score, was developed by Dr. Huria and her colleagues. In this paper, published in JCO in 2011, titled Predicting Chemotherapy Toxicity in Older Adults with Cancer, a validated 11-item tool that integrated geriatric domains such as function, comorbidities, cognition, etc., was developed to generate a risk score. It predicted the specific risk of grade 3 to 5 chemotherapy toxicities with greater accuracy than physician-rated performance status. Its clinical impact was for the first time oncologists had evidence-based tool to frame risk conversation with patients and guide decisions on treatment intensity. There was also another tool that was developed by Dr. Exerman called Crash Score in 2012, which had almost the similar components to CARG score. In the same era, there was a rise of choosing wisely, proving the safety of de-intensification. In the CALGB 9343 trial, a 10-year follow-up data on women aged 70 and older with low-risk hormone receptor positive breast cancer were analyzed and reported. In this study, it showed that omission of radiation with older women with low-risk breast cancer does not impact the long-term survival. This was extremely important because it prioritized avoiding toxicity. In 2018, ASCO incorporated geriatric assessment into their guidelines, and it suggested that all patients aged 65 and older who are candidates for chemotherapy should undergo a geriatric assessment to identify vulnerabilities. The single guideline institutionalized the geriatric assessment, elevating it from a specialized tool to a universal standard of care in the United States. In the fourth era, 2019 to 2024, it was the era of interventional breakthrough. After decades of observation and prediction, landmark randomized trials finally answered the ultimate question: does performing a geriatric assessment actually improve outcomes? And the answer was a resounding yes. In the GAP70+ trial by Dr. Mohili and colleagues that was published in Lancet 2021, they randomized over 700 patients aged 70 plus with advanced cancer. Patients in usual care group were 71% likely to experience high-grade toxicity, compared to only 50% in patients who underwent geriatric assessment and received some geriatric interventions. So geriatric assessment guided care and management reduced severe chemotherapy toxicity from 71% to 50%, leading to 21% absolute reduction in severe toxicity. It's important to note that this was achieved with no detriment to overall survival, proving that GA-guided de-intensification is both safer and equally effective for older patients. Around the same time, multiple other randomized trials have also been reported. In the GAIN trial, a multidisciplinary geriatric assessment-driven intervention reduced severe toxicity by a further 10%. It reinforced the value of team-based approach for this patient population. In the INTEGRATE trial by Dr. Su and colleagues, integrating geriatrician-led care reduced unplanned hospitalization by 41%. It reinforced the impact of health system utilization and patient quality of life. In Jericho trial by Dr. Lund, in colorectal cancer patients, GA-guided care increased the rate of chemotherapy completion. It reinforced that safer care can also be more effective care. In the same era, more evidence on the value of de-intensification emerged. In the PRIME2 trial by Dr. Kundleker that was published in New England Journal of Medicine in 2023, for women aged 65 plus with low risk early breast cancer, although omission of radiotherapy was associated with a higher rate of local recurrence of the disease, however, there was no difference in overall survival or distant metastasis-free survival at 10 years. This confirmed that for many older women, omitting radiation is a safe and reasonable choice that avoids a significant treatment burden. So the insight from this era was that the evidence is now irrefutable. An oncologist working in isolation cannot provide optimal care for an older adult. Geriatric assessment guided, team-based management is the new standard. GA-driven care is proven to reduce severe toxicity. It reduces unplanned hospitalization and improves treatment completion. And the 2023 ASCO guideline updated the GA mandate to include immunotherapy and targeted therapies as well. Finally, the current era, the 2024 to 2026, the new frontier. With the core clinical questions answered, the focus shifted to implementation science, global equity, and seamless integration into daily clinical workflows. The 5C trial by Dr. Putz in 2024 exposed that even modern geriatric oncology trials still enroll patients who are younger and less frail than the real-world clinic population. A newly formalized concept quantifying that older patients with metastatic cancer spend 21% of their remaining life in healthcare contact, highlighting time as a critical patient-reported outcome. And finally, Research by Dr. Lowe in 2025 focused on identifying and closing significant racial and ethnic gaps in the application and outcomes of geriatric cancer care. So the future of geriatric oncology is both global and digital. For global, ASCO 2025 Global Guideline provided the first resource-stratified framework for implementing geriatric oncology in low and middle-income countries, ensuring equity on a global scale. And for the digital integration, the PACE-70 study, which the result is expected in 2026, is evaluating how the ASCO Practical Geriatric Assessment, or PGA, can be integrated into electronic health record to trigger automated dose modification alerts, making geriatric assessment feasible in busy clinics. So in geriatric oncology, in advanced non-small cell lung cancer, in 1999, ELVIS trial proved chemotherapy provides some survival benefit over supportive care for older adults who are able to tolerate treatment. 2003, the MILES trial established that monotherapy was often safer than doublets, introducing de-intensification. And today, geriatric assessment is used to guide decisions between platinum doublets, single agents, and immunotherapy. In early breast cancer, there was a story of safe omission. In 2013 and 2023, studies showed that older women with low-risk disease can safely avoid radiation without impacting their overall survival. And in colorectal cancer, 2001 study proved survival parity for fit elderly receiving adjuvant chemotherapy. And in 2022, Jericho trial, geriatric assessment guided management increased the likelihood of completing curative intent chemotherapy. So the 30-year journey of geriatric oncology can be categorized in 5 eras. Era number 1, era of awareness from 1996 to 2000, the problem was established. The second era, the era of standardization, we developed comprehensive geriatric assessment. The third era, from 2011 to 2018, the era of prediction, we developed the models such as CARG. The fourth era, the era of intervention, from 2019 to 2023, we proved the impact of geriatric assessment and geriatric management. And finally, in the fifth era, which we are currently in, is the era of implementation, driving global adoption. So the clinical vision of geriatric oncology is treating the patient, not just the pathology. The evolution of geriatric oncology represents a triumph of evidence over bias. We have progressed from documenting a problem to mandating a proven interventional solution. The geriatric assessment is no longer an academic exercise, but a clinical imperative. It's the tool that ensures that we honor the complexity of our older patients, tailoring therapy to their unique physiology and priorities, and truly fulfilling the mandate to first do no harm. If you appreciate and enjoy this presentation, I highly suggest that you subscribe to the channel, like this video, comment on the video, so we can grow our community on the YouTube platform. Again, this is Dr. Armin Shahrokni. I'm a geriatric oncologist.